Get started. I'm sure others will join us as they are able. Um, so welcome to Project Echo Dementia for our August 23rd, 2024 session. I'm Chris Rhodes. I'm a neuropsychologist and professor of neurology here at the University of Washington and have been your co-lead for this wonderful project since its inception back in 2020. And I'm going to go ahead and share my screen as we get going here. Hopefully you can see that okay. It looks like you can. So as usual, here is our kind of standard agenda where we'll do some quick opening notes and reminders. We'll do some virtual introductions in terms of having you or asking you to put your information in the chat if this is your first time joining us. We'd love to know who you are and where you're from and your clinic. Then we have the great good fortune of a wonderful didactic from Doctors Goldberg and VandeKieft on the Washington Rural Palliative Care Initiative. Really lovely companion piece to our prior didactic for our last section around rural brain health from Dr. Justin Miller. We do not have a case today, so we've got plenty of time. Well, we don't have a case from our community. Doctors Goldberg and VandeKieft have been gracious enough to prepare one, but plenty of time for a robust discussion. So a couple reminders, even though it's 2024 and we've been doing this for a while, I still forget to mute and unmute myself. If you are joining from a computer that is a clinic computer or something like that, if you could rename it so we know who you are. And remembering to mute when you're not speaking, and good Zoom etiquette, I guess, to say your name when you unmute, although I forget to do that too. If you're able to turn your video on, we always love that. Great to see your smiling faces and help build our virtual community. Also understand that that doesn't always happen. And then if there are multiple of you in the same location, which is rare these days, but it does happen, if you just put whoever else you're with in the chat also, so we can keep track of attendance and CME. Speaking of CME, here is our process for any of you who are University of Washington staff, faculty, students. You can text that number to that number, or your email address to that number, and then the registration number, and that should get you registered and credit. We'll put this up at the end also, but you may take a photo or a screenshot of this information. If you are not UW affiliated, we'll do the usual thing in terms of keeping track of CME. As you all know, we are fortunate to be able to offer free CME, and also we'll talk about disclosures here in a second. So again, we don't have a case, but we love cases. Cases are part of like the best part of our learning here. We always learn something from them. So if you have one, please reach out to Samantha. Again, no case is too simple, too complicated, too kind of basic or complex. All cases are super valuable. Just drawing your attention to a few other resources. So UW Echo Geriatrics, the TBI Echo, Psychiatry and Addictions, the Telebehavioral Health series. There's also some teleconsultations and case conference series for complex issues like pain and pain management. And then, of course, multiple repositories of wonderful information, including the UW Psychiatry Grand Rounds Archive. I keep threatening to put the UW Neurology one up here too, but have neglected to do so, but that's another fantastic one. A couple reminders for any clinically relevant issues or cases. We do our best to protect PHI. We can always go back and edit it out later on, but it's better to do so proactively. And also to that fact, all of our sessions are recorded and available online on our website. And as always too, we will solicit your input around what's working, what's not, what could be better, what's going well in our 1-minute post-session survey. Thank you for those of you who fill those out. We go over them in detail and have made some modifications over the years to try to make this a better learning community. We're accredited through the UW, certainly only claiming whatever credit is commensurate with your participation. Neither our speakers or our planning committee have any relevant financial relationships to disclose. And anytime there is a disclosure, that process is subject to a rigorous mitigation process through the UW, as you might imagine. But also, I've said it before, I'll say it again, that if you ever do perceive bias or have concerns, please reach out to Nancy or me, or put that in the chat, or not the chat, but maybe your survey. Always happy to review that. Here's our hub team. And I think for those of you who have been with us for a while, you know us well. Here are most of you. I think we've got some new attendees that may not be fully represented with our stars here, but at this point, we're up around 90 sites and about 225 providers who have participated over the years, and always interested in growing our community. And with that, I will turn it over to our fantastic didactic presenters today. So Dr. Adie Goldberg, who is a psychiatric social worker and co-director of the Rural Palliative Care Initiative, has been at Providence for the last 6+ years, and her colleague, Dr. Gregg VandeKieft, who has been at Providence for over 20 years, I think it's 22, and has been medical director of this initiative since its inception back in 2016. I also think I realized where Dr. VandeKief's name was familiar, in that I believe he also practiced up in Mount Vernon around the time that I worked with older adults in community mental health. And you have a distinctive name that rang a few bells. So nice to have you both here today to talk about the Washington Rural Palliative Care Initiative. I'll stop there and turn it over to you.
Thank you, Dr. Rhodes. And I'll take just a moment to maybe add, and yes, I did indeed. I spent 6 years as a family doctor in Mount Vernon before transitioning quite a few years later over to hospice and palliative care full-time. So the background in family medicine, full spectrum family medicine, as well as palliative care. Adie, I don't know if you want to say anything more about your introductions.
No, just that I'm so thrilled to be here and that I've seen many of you in different venues. I'm based in Spokane and Gregg is based over in Olympia. And we worked together for years before we actually met in real time, in real space due to COVID. And someone once described us as 2 mouths and 1 brain. So we'll see how we do this.
Yeah, Adie and I have done some fun work together, including some telepalliative care, direct-to-patient consulting. And the thing I often commented on is I was such a better doctor because she would send me private chat messages of things to ask, and then I would ask them and get the credit for coming up with such an insightful question. So thanks for that, Adie. Well, we're going to start with a fairly brief didactic, just to kind of go over a few different things. Let's see, for some reason, my screen isn't wanting to advance. There we go. So that just is no disclosures and our brief intro and the type of community that we hope to serve through the Washington Rural Palliative Care Initiative. So we're first going to talk a little bit about why rural health is a DEI issue. We're going to also then talk about the Learning Action Network model for statewide palliative mentorship and how we've used that for the Washington Rural Palliative Care Initiative. And then we're going to talk a little bit about some of the resources the WRPCI can offer, including some dementia-specific resources. The work we've done has primarily been more broadly palliative care, but one of the things Adie and I have really discovered is the cases that get brought to us are frequently not palliative care like many of us would assume, people imminently approaching the end of life, but it tends to be people living for years with chronic comorbidities, advanced clinical comorbidities. And so it's really broadened when you go out into the rural communities, the conception of palliative care is much broader than I think people often stereotype it. About 1 in 7 Americans live in a rural place, and there are unique elements of are you seeing the screenshot of all the individuals, or are you only seeing my slide?
Only the slide.
Okay, good. So about 1 in 7 Americans live in a rural area, and The biggest challenge tends to be geographical. There are certainly economic and cultural elements, but geography plays the biggest role. When you're up in the Okanagan, getting access to subspecialty care means typically trekking to Wenatchee. If you're up in Stevens County, it means going to Coeur d'Alene or Spokane. And for many people, that geography can be a significant barrier. And so, even in addition to economic and cultural elements of access to healthcare in rural settings, is just the pure geographical element. And there are studies that have demonstrated that the health is consistently or worse health is consistently associated with lower education or income. And so in rural settings, we see more frequent cancers, maternal morbidity, opioid misuse, a lot of the critical services. You see articles in the newspapers lately about how many critical access hospitals have stopped providing perinatal maternity services. And so if you live in a rural area, you may have to trek quite a ways to be able to get proper prenatal care or to have the delivery, unless you have a midwife in the community or somebody who can work with you locally. And that gets exacerbated even further for people of color, for many of the similar reasons that's exacerbated in urban settings. We still haven't done away with racism in this country by any stretch, and that is as true out in rural settings as it is in urban settings. And so again, we see one more element of equity issues around health outcomes for people in underserved communities. So how do we rectify some of these challenges? Part of it is the model that we're going to talk a little bit about, the Learning and Action Network, which is very much a peer-to-peer thing. It's not so much that, hi, we're the experts from the University of Washington, or we're the experts from Sacred Heart or St. Peter. It's more, what can we learn from you about your needs and how we might be able to meet them? And what can you learn from one another about innovative ways to meet the needs in the communities? Adie, I'm going to pause just a second and put you on the spot because you've done a lot of work with the community needs assessments and some of the other upfront work with the Learning Action Network. And I'd like to hear some of your thoughts about that model.
Well, I was really glad, Greg, that we talked about how you can learn from each other, because what I would say is that as we develop cohorts, we try to do some pairing so there's cross conversations, so that we might have different communities at the same stage of development of a palliative initiative. We might have them linked because of population size, access to professionals. And so truly what I think is part of the beauty of this is that we, Greg and I, and the panel of experts really step back and have learned tremendous amounts from these conversations. And, Greg gave me credit for helping him be a better practitioner. I would say that I would give the cohorts much kudos for making me a better practitioner when I look at rural communities, as I've learned from them and actually sat in awe of them.
Thank you, Adie. I was trying to pull something up here while you were talking, so sorry for the
Want me to keep
pause.
talking? Do you want me to keep talking? I can.
Well, let me advance the slide one, and then we'll take a look and see.
Okay.
Hang on, my slide advancing has been a bit wonky, but here we go. Yeah, if you don't mind continuing on a little bit more about the Learning Action Network.
So actually, this sentence, "cancer doesn't happen to a patient, it happens to the community," came from a palliative care RN in a small community who went to pick up a latte at the local latte stand on her way into the hospital. And she was handed two lattes because the barista said, oh, the local emergency responder for one of their organizations had been hospitalized, and she happened to know that this was the responder's favorite latte. And so she actually found out from the barista what was going on in her community. So these assumptions that we hold on to when we think about the expertise lying within the community is every organization is best equipped to set their own goals and pace. And we really set the bar, let the community set the bar, and just acknowledge any progress is a success. We're not prescriptive, and everyone teaches and everyone learns, I think. And so one of the lines that, even though Gregg has an MD and I have a PhD, all of our community participants have a PhD in their community. And so this is where the learning for everyone comes.
Yeah, and it's been a lot of fun and often, and we'll talk more about the specifics of the model and how we do our case consults. But near the end of our case consults, we often will ask, what are some of the key points you're going to take away and use? And it's been really striking just how commonly simple comments have had a really meaningful impact through the case presentation. And the other thing is how much affirmation we can authentically provide about the incredible work they're doing in their communities with patient care. They're strapped for resources and they MacGyver their way through to successful patient cares with good outcomes just because of their commitment to their community. Okay. So the Washington Palliative Care Initiative was initiated in 2016. The executive director of the Washington Department of Health's Office of Rural Health, Pat Justice, had a vision for it. Pat's based here in Olympia, and when we were developing our inpatient palliative care program at St. Peter Hospital, Pat actually helped me do some really creative stakeholder assessments. We convened all the medical directors of 21 different service lines in the hospital, held a conversation over dinner, and Pat helped record the conversation and got a grad student to do a thematic analysis and really pull out what are the key themes of what the stakeholders are looking for in a palliative care service. And it really meaningfully impacted how we shaped our service. Well, Pat takes that concept and that model and says, well, let's look at rural palliative care and how do we suss out what are the needs in the rural communities? How do we do community assessments? These are the people who know best who the key players are, the key stakeholders. It might be a long-term care facility, it might be a pharmacist, it might be a chaplain, might be a family physician, and in each community that's very unique. And so that learning action model that Adie was talking a little bit about is so important so that one community can hear from another what worked best for you, and is that something we could replicate in our community? Now I'm going to stop sharing for just a second and go to a different screen because one of the things I wanted to show you, so this is the webpage for the Washington Rural Palliative Care Initiative, and that's in your resources. But what I wanted to show here is just the map of the state of Washington. Over the 8 years this project's been active, we've had 3 different cohorts. We started with a cohort of 7 communities. I think we added 7 the next time and 6 the third time. And so we're up to 20 different communities around the state, all small communities. Dr. Rhodes mentioned I practice in Mount Vernon. We actually talked with Mount Vernon, but we kind of scratched our heads and said, are they rural enough, or is that still a sizable enough community? It wouldn't really apply. So we don't have any communities of that size. These are all very small communities. Many of them, that's a critical access hospital. That's the main center of the healthcare service delivery in the community. Some of them are coming out of federally qualified health clinics. Some are volunteer programs, like up in the Okanagan. They have a program called the Lookout Coalition. And if you look at Okanagan County, Raleigh Bowden, who is a retired oncologist that works up there, likes to point out Okanagan County is larger than the state of Connecticut. And its rural population is so sparse that they actually aren't even classified as rural, they're classified as frontier. And so we're serving some very sparsely populated areas. And now I'll come back to the slide deck.
And while you're doing that, Gregg, I just want to add that there are other communities waiting to be onboarded. And so we continue to grow this initiative as the word gets out.
Okay, I'm going to.
And the one thing I do want to add, Gregg, while you're searching, as you stall for time, is we are always happy. If you have a question that comes up in the midst of a presentation, don't feel like you have to wait till the end. It may not be as germane when you wait 10 minutes to ask it as it is in the moment. So please feel free. We're a small enough group. I don't mean to be violating your norms, but please ask a question.
In 80, I think I accidentally just put my notes slide back up. So
You did.
what? Okay, so let's go to slideshow from current slide. How's that?
Now you're good.
Okay, good.
And so we just did this slide
There we
and
go.
there we go.
So this is just kind of a fancy way of modeling the assessments we do, starting with, how is the development process going to look for this community? Pat, as our executive director, who unfortunately for us, but happily for her, just recently retired. But she was really good at finding out, okay, how do I go about relationship building in the rural communities? Um, and then developing community profiles so that we understand what are their needs, what are their resources, at kind of an asset and gap analysis, looking at how do we map out any data we have to demonstrate need. Um, Finally, starting to prioritize things, creating documents, put together a plan, and then actually implementing and evaluating. Adie, you've been involved in this quite a bit, so I'll also ask you to comment on it.
Sure. I think what the interesting thing has been for us is that when we look at the community profile back on 3, we're really looking at who might have the skills to do it but isn't currently doing it, who might be interested in doing it but is not formally tasked in doing it and needs more education, or who's someone who we pinpoint thinks needs to be doing it but they haven't realized that yet. So that developing the community profile is really a deep dive into what is needed as we have built palliative understanding in a community, who's doing it, who wants to do it, who needs more training, and that's when we step in.
So the model itself, we have multiple disciplines. So Adie and I are here as a physician and a social worker. We have a pharmacist, we have chaplains, we have nurses, um, administrative people. Am I missing anybody, Adie?
We've had an activities therapist, we've had PT, OT. We really have tried to make it as robust as possible. Understand home health has stepped in with their nursing staff. So we try to make it as robust as possible with the resources that exist within the community.
Yeah, and just for clarity, what I was describing was more the hub team. Adie's
Oh,
describing more who participates from the various cohort communities. And
right.
so the hub team is kind of the disciplines I mentioned, but we really like to think of this broadly. And interesting timing, Adie, just in the last couple of days, I've been doing some work with occupational therapist and speech and language pathologist around comfort care patients because so often as a therapist, the mentality is, oh, well, if they're going comfort care, it's time for me to sign off. Well, this patient needs swallowing for comfort. They need some physical abilities for transport or transferring for things like toileting. The therapists have a lot to offer comfort care patients, and it's been really rewarding to have disciplines more broadly participate in the program and learn what services they can provide, even when the patient no longer has significant rehab potential. So what is the model we're looking at? I think we've covered most of the stuff that's on here.
Greg, you want to speak a little bit to the culture change? Because I would say that's the enduring piece that, players may come and go, but how can we embed a palliative mindset in the community and how that has impacted us moving forward with WRPCI?
Yeah, and I can think of a couple of different communities, Adie. I appreciate that call out that have had anecdotes that really highlight how culture has changed. For a time, Adie and I did a fair amount of direct patient consultations to the critical access hospitals in Stevens County, but Providence wasn't able to sustain that program economically, and so eventually it was closed. The nurse who was the primary person on site in the critical access hospitals in Stevens County has let us know that she now hears hospitalists there using language that they learned during our consults because they would often sit in on the consults. Asking the same questions. So, I lead off a palliative care consult typically by asking, well, tell me about your situation right now. A very open-ended question. Get a little bit more about what their hopes and expectations are, and then directly saying, based on all the information you've received, when you look at the future, what are you hoping for? And she said that she is now seeing the hospitalists routinely, the ones that participated with us, routinely doing that sort of thing on their own. She's getting a lot of calls from nurses and hospitalists saying, is this a patient that ought to be involved with palliative care, that 2 years ago, 3 years ago, that she would not have gotten those same calls. And so a lot of these initiatives, I worry, are done as one-offs where somebody shows up, gives a great series of lectures, does an in-service, and then they leave, and a year later, things have regressed to the mean, and there's been no impactful culture change. And so it's been grateful as we continue these sessions with the communities. We have a monthly online session at minimum, often multiple times per month, that we're seeing that the culture change has been sustained in other ways. Dayton has a very different model. It's less of an inpatient there, that theirs is mostly outpatient, but they've seen a number of the patients that their palliative care team is now working with in the community setting have dramatic reductions in hospitalizations and emergency department visits, or even just having the paramedics come out. And in a lot of rural communities, the paramedics get to know patients on a first name basis because they get called out often enough and their neighbors and everything else. And so, yeah, again, seeing that enduring culture change. Adie?
Just one more culture changes. Oftentimes, what communities are giving us feedback is that they hear, my aunt had your service, my uncle had your service, my neighbor had your service, and I want it now for whoever it is they're treating. So, one of the things in rural communities is word of mouth is a great culture changer.
So some of the different activities that the Washington Rural Palliative Care supports, as we mentioned earlier, the community health assessments, and Adie, looking forward, we're talking about new communities. Are there going to be new communities coming into the WRPCI?
We're hoping to have, we have 4 in the parking lot who are waiting for a critical mass. And so if anyone online is participating in a community that is not represented, or you want to know more about it, please reach out to Gregg or me, and we will get you in the parking lot with the other 4 communities. We try to bring on a critical mass of 5 or 6 so that there is support for each other.
And so as the communities come on, that's where the community health assessment takes place. And then there is reevaluation periodically. Roughly, is it yearly, Adie, that you kind of go back and look at the plan and say, do we need to modify the plan at all?
The original group of stakeholders is reconvened, and any new people who might have been involved in the process also are invited. And we basically look at that asset gap analysis at the end of a year and see where we are, where we sort of missed the mark, where we exceeded the mark, and how we can provide resources that allows the community to move forward. It is also with great respect that we sit with the community to see what it is they feel is now, after a year in, more of a priority for them rather than us driving that priority.
The mentoring is a little bit more ad hoc, and we've done that with multiple communities where, for instance, we had one community where a family physician and a nurse practitioner just wondered some things about specific clinical questions. They arranged a consultation time with Adie and me. We had a Zoom interaction, I think twice for an hour, and we were able to cover some of the clinical management questions they had, just as mentoring them in their community, since they don't have the opportunity to necessarily access specialized palliative care resources within their community.
Additionally, we have formally scheduled mentoring for new communities for their first year. That tends to be once a month. Historically, it was with Pat and myself, and then an established cohort team member. So we now meet with the cohort 3 on a regularly scheduled basis, just to hear if they have any questions, concerns, what resources they're needing, where they want to revise plans. So it is both the informal PRN as needed, and then also a formally structured mentoring process.
Office hours is just a regularly scheduled time. It's once a month, a Thursday at noon, that Adie and I both make ourselves available for anybody who wants to just drop in and have a conversation. Sometimes Adie and I talk to each other and nobody drops in. Other times we have 4 or 5 people dropping in. Often they'll connect with us in advance. We had a team out on the Olympic Peninsula who connected with Adie and me to say, we've got some operational and workflow questions we'd love to run by you tomorrow, and gave us a little bit of preparation so that then when we met with them during office hours, we had some background on what it was they were hoping for. Probably the major activity, well, I'll drop probably the major activity we do ends up being our monthly case consultations. Once a month at 12:30, we do something that's kind of a Project Echo light. We actually seriously looked into making it a Project Echo initiative, but decided that we wanted to do the case consultations and deliberations without requiring a dedicated didactic session. We do our didactics separately, and Echo out of University of New Mexico really wants you to adhere to their model if you're going to use the Echo label. So internally, we often jokingly call it Echo Light. And so each community has the option to sign up for a given month to be the presenting case. So they come in and they the week in advance they submit the case as a written case that Adie, me, all the other hub team members review and have an online dialogue about in the portal that we have through the Department of Health's website. And then we come together on a Tuesday at noon, and the team who submitted the case, one of their team members presents the case to all the cohort participants. Typically, it's attended by something like 20 something people. We've had as few as a dozen, we've had as many as 40. Like this Project Echo, I suspect that your attendance varies depending on how busy people are, what the presentation's about, and everything. And then the case members all, or excuse me, the consultation team members all will comment on the case. Usually I take the lead role as the medical director. We'll talk about some clinical things. I'll call out questions, pharmacy questions to Kristen, our pharmacist, like a social, spiritual questions. We have, like I said, chaplains on the team, social workers on the team. There's also a lot of support to the local team members. They're often feeling like, my goodness, am I doing a decent job here? Am I in over my head? Is this a patient that's too complicated? And 90+% of the time, instead, it's the exact opposite. You people have done such an amazing job with the limited resources, but here are some things. Then we put together some recommendations. Near the end, we ask, what are you going to take away? And then Adie will share with you in a little bit the written summary they get afterwards that can kind of help them, guide them in the case. Didactic offerings are just what it sounds like. These are intermittent. They don't have necessarily a regular schedule, but like last fall, Adie and I and Kristen, our pharmacist, did a series of, I think, 8 different hour-long didactics over a 2 to 3 month period, and all the cohort teams were invited to attend, and they were on various things from complex pain management to GI symptoms and so on. Curbside consults, again, that kind of sounds what it sounds like. The providers are welcome to ping me to say, hey, Gregg, I've got a complicated case. Can I talk to you about it? And in my role as medical director for this initiative, then I have a formal relationship I can do. And Adie does the same thing. I suspect Adie actually does more of it than I do. And then site visits, they took a big hit, as you can imagine, during the pandemic. Adie recently went out on a series of site visits with Pat. I haven't done any since before the pandemic, but again, that's just what it sounds like, going out to the community, providing the asset and gaps assessment, helping provide some added support to the workflows. Adie, before I move on to the next slide, anything you would like to add to that?
Just a couple of things. One of them is that, I'm aware, and I've been on a couple of the Dementia Echo, how there aren't cases. And I think one of the beauties of this model is we have a designated hub person who coordinates the case presentation, and actually we have a template that we assist them in filling out if they have any questions, because they haven't been able to present before. They don't have to have an active program. It can be any member of the community who steps forward. And so I think that's one of the lovely pieces. So I just wanted to add that about cases. As far as the site visits, I think what's been most valuable for me, having gone to about 9 sites now, is seeing where people work. There's, nothing more valuable than understanding where ED is situated in terms of the waiting room, where people try to have their conversations, walk around the community, And so I think one of the gifts for me in these site visits has really been to see the site itself. And in rural communities in particular, there's nothing better than a good handshake.
So what I really want to know is, did Amber take you to the latte stand that you were talking about earlier?
She did. And I also got to see where the whole staff goes for happy hour afterwards. So
Okay. So here's some background material, including our email addresses. I'll leave this up for a little bit. The top bullet point is just a thing I did for the Department of Health to share with the local communities. It's a video. I don't know what, 6 minutes or something. Then there's an announcement of a tipping point award. So this project recently was one of three of over 100 applicants to win a tipping point award put together by the John A. Hartford Foundation and the Center to Advance Palliative Care. And so we were very pleased and proud to have that type of acknowledgement and affirmation. And then the portal, as I demonstrated earlier, is where you can find access to this. And again, if there are individuals in communities that would have an interest in participating, let Adie and me know, and we can see, if we can get that critical mass of another 5 or 6 communities together to add yet another cohort over time. So Adie, I'm going to unscreen share, if that's a word, and then you can put up the case commentary summary that we talked about earlier.
yeah. So let me get to my screen share. And first, what I wanted to do, hold on, share. Let's see if we can get it. There's Mrs. Whoops. Okay. So you can see just real quickly, I just want to have the current slide. This is Mrs. M. And this was a case that was presented. And she was 93-year-old female. She was admitted for aspiration pneumonia, sepsis. She had all this laundry list of other issues. But I think what was most important for this purposes of today, she has a history of dementia. And in fact, she had a documented loss of decisional capacity since 2020. Currently, she's unable to pass her swallow test, and her BMI was 13. So maybe I'm going to stop screen sharing and ask you how this kind of a case resonates and what in your communities you might have done for this patient. So we'll open it up. And Gregg, you can add anything to questions that you want to pose to the community as well.
Well, I just will add one disclaimer that Adie and I did make a point of anonymizing this, so it's really a composite case, so that we made sure there was no PHI being shared.
Thank you for making sure that was covered. Anybody have any thoughts about this patient? Yeah.
I'm Kathy. I'm a palliative care social worker at Auburn Medical Center. Whoops. And my first thought, we get a lot of consults with persons living with dementia, especially with our Gero Psych unit here.
Mhm.
And the first thing that we find out is how much people don't know about dementia. And so a lot of her symptoms would be related to her disease, and how the family and wouldn't really maybe understand that. And so just really taking time to go through what's going on with her and normalizing it in the sense of her disease, and then helping support them through that is the first thing that came to my mind. Education is very powerful when they look at someone that is withering away, right? That's pretty much what she's doing. So I find education about the process of dementia is what we're really missing when folks come in to the hospital.
Thank you so much for that, Kathy. And that is true. And the palliative care team did get involved. This patient amalgamation had a son who was her designated POA. They did have that paperwork already on file. And they did have a pulse, which said, do not resuscitate, but full treat. Okay, so they had completed that documentation. The son's hope for this case was that he he brings her back to the hospital in the hopes that he'll get her better so that he can bring her home again.
As Kathy was talking about education, I'll just call out two resources from the Department of Health that I suspect many of you already know about, but for anyone who doesn't, the first would be the Dementia Roadmap. Um, Wonderful document, looks at everything from mild cognitive impairment all the way through advanced dementia, and helps families understand kind of the natural clinical history that they can expect as a person with dementia progresses through their illness. At the Washington State Hospice and Palliative Care Organization, we were so impressed with the dementia roadmap that we plagiarized it and created a palliative care roadmap. I guess I'm giving attribution, so it's not plagiarism. The palliative care roadmap is a very similar document, going all the way from being worried about symptom burden through advanced illness and end of life care. And so those are two resources. And if you Google those, Washington State Dementia Roadmap or Washington State Palliative Care Roadmap, easily accessed online with ordering information.
Thanks, Greg. Other resources that we've used have been the Hard Choices for Loving People. I don't know if folks are aware of that one. And also the Choosing Wisely recommendations are other ones that we often will make available to folks in the community. And you're shaking your head, Kathy, like you're aware of those resources. So great.
And this is Chris. We will be happy to send out links to those resources with our follow-up email for today. So thank you for bringing those up.
Wonderful, wonderful.
So Adie, this patient's son wanted to return home, so I would be curious what this caregiver support is like in the home setting. What's he going to do when he has to go work the fields or go to the factory or whatever it is he does for a living?
Well, that's a great question, which the team in the hospital asked a lot. And he would leave her at home, though ultimately, being a person who lived in Washington State, he is her paid caregiver now. But he still has to leave and go to the grocery store and things like that. The hospital ED has been his primary source of care for her. That and the local EMT when he can't get her off the floor if she somehow slips.
And
So,
one of the things you and I learned, Adie, when we were doing direct to patient telehealth consulting is we would sometimes suggest home health or hospice, and we would be told, oh, well, where they live, there is no home health and hospice. They live so remotely that they're in a home health or hospice desert, which I didn't know existed until doing a lot more rural health. So were they going to be able to get any of those type of resources?
well, I think one of the real issue has been sometimes the issue has been caregiver availability at the home health level. And what we saw with COVID is just a real hit on paid caregiver availability through agencies and rural resources, which is another support services for communities. In this case, her son didn't want help in the home. English was not their first language, and there was some mistrust. He had great faith, and his church community became his primary resource. And Gregg, you and I have seen that very frequently, where the church community and rural community is the primary go-to set of extra hands on deck.
One of the other things Adie and I came to appreciate with a lot of this work is the sense of connectedness to the land that many of the rural people have. You know, they live out there because they wanted to own land, they wanted to work the land, and so being in their own home on their own land means something to them quite often. So. That's part of the challenge is if you don't have a resource for the round the clock caregivers, hospice and home health comes out for a little while, but what do you do in between their visits, especially if you work and you don't have a large family who can develop shifts to do the work. So faith communities, sometimes neighbors, things like that become such an important facet of the care in those settings.
I've been in several presentations of late where we've talked about the urban hub being where we hope to get these folks. But, as Gregg said, attachment is to the land. And urban hub is not necessarily, and treatment is not necessarily the solution of choice for many of the people that we're dealing with in rural communities. That more than getting a specialist opinion or a treatment facility that does, memory care, which is not available in most of the cohort communities that we work in. People want to take that on in their home rather than have their family relocate.
And I think if I can just speak up again, that's where my emphasis is on teaching care partners the techniques to work with their loved one, whether it be dementia or if you have to take them home and you don't have extra services, teaching people how to care for their loved one. This is how you help someone turn. This is how you help someone get up. And I would love if in palliative care we could put that in like our outpatient ways, especially with if somebody has someone living with dementia. I mean, that's my passion. You know, there's like I'm a Teepa Snow. I've drunk her Kool-Aid, and I really love those methods, and they work. I use them up on the units when I'm working with people, and I feel like we're missing the boat on not helping families get the hands-on. This is what you do. Okay, we say distract the person, but hey, there's techniques to do that. And I wish in the rural communities, especially, we could offer more robust, hands-on. That's what's going to make their life better and easier is if they know what the heck they're doing, and then they have something to fall back on. That's my soapbox of what we don't provide to people.
We accept your soapbox and the challenge, and many, I have to say, of the providers that we see on the call do that and end up being the people who make multiple visits way beyond what is reimbursed to reteach these lessons. I think the big issue has been, of course, distance, lack of payment, lack of staff, and I know this is not surprising to anyone on this call.
Well, Adie, you mentioned something about transitioning to the urban hubs, and Kathy, you talked about soapboxing. So I'm going to put those two together and get on a soapbox here just a little bit. One of the things that people often look at when you're able to get higher levels of palliative care services into the rural communities is cutting down on the number of transfers to the urban referral centers. I like to flip that conversation though and start with where we're really coming from is goal-aligned care first and foremost. We're not preventing transfers to save money, although it does. We're preventing transfers to provide the care that is better aligned with what the patients and their families want. And they frequently do not want to have to go 200 miles away or even 75 miles away to a referral center. They frequently don't want to be in the hospital, or if they're going to be, they'd rather be in the small hospital in their home community. And so Adie and I really found that when we were able to beam into those critical access hospitals and do consults and really articulate or help the patient and family articulate what their goals of care are, what their treatment preferences are, it really did reduce the number of transfers. We had one case in particular that will always stand out to both of us where the hospitalist that came on after a consult had been placed, canceled the consult. They sent the guy to Spokane and he declined the intervention that he was sent to Spokane for. He said, I don't want that. It's not what I wanted. And they sent him back to the small hospital, and then they did re-engage Adie and me. And so it is really goal-aligned care is where this has to start.
And the sending him back, of course, was at the expense of the family because he was going back to a lower level of care. And so, the financial complexity and burden on families of giving them, a palliative care doc always says the most expensive care we offer is unwanted care.
And then the other thing I would comment on, you talked earlier, Adie, about culture change, is the impact on the caregiving staff at the hospital or the clinic or wherever they're doing it. When our telepalliative care initiative was shut down by Providence, one of the hospitalists literally came up to the palliative care nurse at Mount Carmel Hospital, wrapped her arms around her and started crying, saying, I don't know what I'm going to do without palliative care. Well, that's where the culture change matters, because the caregiving teams have all commented about how different it is when people have really integrated palliative care principles within the delivery of their services. Some of you have heard this story before, but when we started our program at St. Pete's, the biggest critic, the biggest skeptic, why do we need palliative care, was the director of our ICU. He just said, I take care of the sickest people every single day. I take care of dying people every single day. Why do we need a special team to help me do that? Well, 2 years later, he would see me in the ICU and hold out his patient list and say, "Can you just see them all?" And in a public setting, this I almost fell out of my chair after his initial outspoken skepticism. He said, when Gregg was proposing a palliative care service at St. Peter Hospital, I didn't see the need. But I can tell you now, in the last 2 years, it's been probably the biggest culture change in our ICU, because it's not just the patients they see, it's our staff have now really fully integrated the communication skills, the care principles of palliative care that they are learning from that team. And so that's where, when Adie talks about culture change and sustainability, the other thing that gives me a lot of hope is younger physicians, and I'm going to say physicians because that's my discipline, are coming out of their training having had palliative care as part of their medical school, their residencies, their fellowships. And I'm seeing docs in the under 40, maybe even into their 40s, who have a very different orientation towards what palliative care can offer compared to my cohort, where it was more of a mid-career introduction of a new concept of care. I say a new concept of care, maybe more new medical specialty would be the way to put it. But when Adie and I would do telehealth consults with younger family docs and internists in the room, I was repeatedly blown away by the sophisticated level of communication skill and interaction they demonstrated right out of training, that I'm like, boy, I didn't get training like that when I was their age. So it gives me hope for the future.
So when we had this case on the panel, what we were at, thanks, Gregg, for that. Absolutely. I'm sorry, I didn't mean to.
No, it's quite all right.
So what the panel wanted to focus on was really, how could we maintain some sort of seamless care for this patient that was bouncing between home and the hospital, and a rotating cast of hospitalists who had to have the goals of care conversation yet again with the son, because they were having a lot of distress and confusion around how do we do DNR, full treat, watching the patient dwindle. And then the other goal we had was, how can we align and honor what the son is asking for, understanding his relationship with his mother, while still acknowledging the distress that was going on for the caregivers in providing that kind of care plan. And so I'm going to screen share, and I'm not sharing the first page, but this is sort of a summary. And I'm not sharing the first page because it has some medical information that could identify the patient, but here we go. So this is the kind of summary that the patient, we would give a patient. First we identified the issues, the macro issues related to this case: ethics, suffering, the rotation, discontinuity of care, and then the micro issues that the son believed was still hoping for a miracle. And then we acknowledge that sometimes the solution ultimately is going to be death, that we may not be able to exquisitely create a plan that would allow for what everyone is hoping for. We looked at the ethics, which always comes up for communities, and how to involve ethics. We talked about futility. We talked about, the different pathways for an ethics consult, whether it was consent, assent, or dissent. And so we went through all the different pathways that an ethics consult could have approached this case. And then we looked with the team at the cultural, spiritual, and emotional issues that were impacting this particular case. Acknowledging that they've probably done it all. Grieving and support. We talked about the grief that the son was feeling and experiencing at this point in time, acknowledging it. And then ultimately, how do we take care of the team who's providing this care? Because we were not consulting directly with the patient or her son, but with the team that was having to provide this care. And so, dealing with feeling like a failure, the self-judgment, realizing there might be a different way, but not being able to implement the different way. And then we always end with the kudos for the team and the recognition for the team that delivers the care. So after every one of these consults, a team will get this kind of a summary of what the panel discussion was. And this is posted on the portal so that not only the team who presented the case has access to this information, but any other team who is dealing with a dementia case or a similar type of case can access that information. Greg, did I leave anything out on the panel discussion and how we handle that?
I think so. I think you covered that nicely. Thanks.
So, go ahead, Greg.
Oh, I was just say one of, I don't know if this is quite the right time, Adie, so I'll ask you whether I should screen share some of the dementia resources that you have posted on the portal.
Sure. And then I'm aware that it's 10 after 1 and I want to be respectful of people's time. So we always end our panel discussion by asking you if there was anything that we talked about that you still had a question about, or anything that we talked about that was a particular takeaway for you. But Greg, before that we pose that question, go ahead and share your resource.
Yeah, so are you seeing the 16 things I would want if I got dementia? Okay. And Adie, you know this material a lot better than I, so maybe I'll defer to you if you want to comment on it.
Sure. So this is one of the resources on the portal for Washington State. And if Echo Dementia has other resources that we should be posting on the portal for communities, we'd be more than happy to add this. But this is some of the things that we have offered local communities in dealing with dementia, sort of the 16 points. And then we have, if you keep scrolling, Greg, there's more other articles we have that we would look at. And here's 5 helpful, Kathy, when you talk about the specific behaviors, here we have 5 helpful tips when dealing with behaviors. How do you do it? Very concrete. And we provide this for caregivers within the local communities. And then tips for visiting folks. So, oftentimes we have hospital volunteers or church volunteers. We want to make sure that this information is available to volunteers. So this is also offered as another resource that's on our portal for any participating teams.
This is Chris again. I'm just going to jump in for 1 second, given that there's some resources that we do have that would be wonderful to include, and I want to point our audience to. One is a presentation by one of our former Hub team members around giving a difficult diagnosis, adapting the spikes model for dementia diagnosis. There's some wonderful stuff there. And moreover, our own Dr. Mimi Pattison, who I'm looking at right now, has done a couple of fantastic didactics around palliative care, including her most recent one on May 24th. And those are both on our website. There's actually a palliative care section in there that we'll be happy to add this one to also.
Wonderful. And then we'd love to add yours to ours as well so that local communities can have access to all that.
Outstanding.
So any takeaway thoughts for you that you were surprised by, that you're going to use, that you're like, they need to revisit this, because as people who work with dementia, we want you to know this. We're happy to learn from any experience that we have. Yeah, there's a question. Mimi, please.
Sorry, my electronic hand isn't working. I clicked and clicked and clicked on it.
I love your physiological hand.
And been waiting. So Adie and Greg, thank you. I've had the privilege, you're obviously speaking to my heart and soul today. And I've had the privilege of hearing you before and to hear more about really your transforming care in the state of Washington and how you've applied all of this. And when I look at that summary that you give to the team, what a wealth of knowledge in there and opportunity for learning. So I just want to call that out. And it probably is better than any didactic any of us can give when they're applying it to the particular case and the situation they were in. So, oh my gosh, I just can't say enough about the work that you guys do. My question is, what is the sustainability for this program? I know you're talking about adding 4 more communities. That's very exciting to hear. What does the future hold for the sustainability?
Ouch. I'll do a little bit on it, and Greg, please pick up. Philanthropy. We rely on the kindness of strangers, as a movie once said. I think we get grants We get quite a bit of grants. We apply for grants all over the place. We have funding from the State Department of Health Rural Division. And we get primarily in the form of staff assistance for that, not operational assistance. We run on a pretty shoestring budget, which every year gets even more shoestring. It's like we're down to one shoe. So Gregg, what am I missing besides state philanthropy grants?
So Mimi, that's such an appropriate question. And truthfully, like a lot of these projects, it's very contingent on what's available. So we got off the ground in large part from major support from Cambia. There were some other significant organizations that were major contributors. And then Pat was a master of keeping track of where grant resources were from. And so I think we're funded well into 2025 right now. But you know, to keep it going does mean an active process of seeking out grants and landing them. With Pat's transitioning to new leadership, it'll be interesting to see how much difference does that make. So even our organization, are we that personality dependent that losing Pat puts our future at risk, or are we self-sustainable enough that whoever is the new director, and they're still doing the director search, will also have that same gift of being able to get the right type of grant funding. I don't know if there's a small portion that would be sustainable long-term out of Department of Health funds or not. I don't know enough about the micro elements of the budget, but the bigger picture is very much looking for and securing grant support.
And I do wonder, you know, oh, go ahead, please, Mimi. I don't mean to interrupt you.
This is bread and butter medicine. It should not be grant supported. You know, where are we today in our priorities? Let's get out there and collaborate and advocate so that everybody gets this care. Everybody. And meeting them where they are. That's such a principle in the world of palliative medicine. And it should hold in rural Washington also.
Thank you for that. And just to piggyback on what you were saying, it may be, as we continue to see less and less funding, that we're going to have programs like yours, programs like ours, programs like Jerry Atrix. How do we network together so that we don't all have to pay the electric bill, and can figure out a way to use funding sources so that we can continue to empower the people on the streets doing the work? And that's really what our initiative is about, and this one is as well.
If it means anything, Mimi, they did shift $12 million in funding to the NIH for palliative care research, which is close to $12 million more than the NIH previously spent on palliative care research. And so, you know, we are seeing some inroads in that regard. Now, it's still less than, I think it's like 0.1% of the entire NIH budget, but it's progress. And as one of the slides that Adie talked about, we count any progress as progress.
Great, thank you.
Anyone else, any thoughts, please? Gregg, do you have our contact information that you can leave on the screen? I think it's the last slide.
It is the last slide. Let's see.
While you're pulling that up, I just want to commend you for the community focus and the community responsive focus, the fact that you are tailoring kind of what you do and how you do it to the people who live where they live and how they live. I think that was a real kind of a component that resonated with me. That and the not forgetting about our colleagues in rehab. I think that is so critically important. I do wonder, the thing we run into is they are stretched thin with the traditional kind of rehab oriented things. So I don't know if you have any tips or techniques for helping address that, but boy, access can be kind of tough depending on location and what they focus on.
It has been student internships, you know, have been one way. We've had people writing capstone papers on this and using extending service as part of their capstone research project. Gregg's daughter, who's now Dr. VandeKieft II, just got her PhD in OT and is really interested in extending this into a new population. So I think in rural communities in particular, we're looking to cultivate local. That our experience has been when we try to bring outsiders to the community views them as outsiders, and they don't necessarily understand the cultural norms. So anytime there's anyone in the community going to school that we can support, enhance, train, provide extra information for, that's the route we've been going. But you're right, they're stretched. Everyone's stretched.
So true. And that kind of resourcefulness and creativity is so important, especially when you're in a place that's under-resourced and underserved. And that's another common kind of spirit between our programs here, both the all teach, all learn piece, but that kind of helping develop this workforce and this expertise in the places for people who know their patients and families the best, right? I mean, that's who should be ideally delivering this kind of care.
And I do want to add that there is a resource out of the Department of Health for retired providers that will help retired providers, particularly nurses and rehab folks, if they've let their license lapse or their malpractice insurance lapse, there's support for that if they're providing volunteer services in underserved communities. So sometimes people have retired but still want to do something for their community, and there is support through the Department of Health, at least in the licensure and malpractice piece of it.
I'll just call out two specific resources related to Dr. Rhodes's mentioning on our rehab colleagues. The first is the Center to Advance Palliative Care, CAPC, has a section called What All Disciplines Who Care for Seriously Ill Patients Need to Know. They do include sections for physical therapy, speech and language pathology, and more recently, occupational therapy, co-authored by one Dr. Emily VandeKieft. Woohoo, woohoo. And then Emily also, as part of her capstone that Adie was referring to, put together a webpage called OT Pal, and kind of has the caption, Your Pal, P-A-L-L, for all things OT. And it's got a fairly extensive amount of stuff at the interface between palliative care and rehab therapies. And then just about 2 weeks ago, Emily's co-author for the one CAPC page, that CAPC posted an article where to Washington, D.C., a palliative care physician and this occupational therapist had a conversation in an article about the interface between rehab therapies and palliative care. So I think the word's getting out there that people shouldn't sign off the day somebody goes to comfort care, that there's still a lot that the therapies do have to offer in the comfort care setting, be above and beyond rehab. I don't have good tips on the stretched thin portion and how to resolve that. I wish I did, other than better budgets.
Outstanding. Well, this has been such a wonderful didactic and just conversation on such important work. Thank you both so much. I'm wondering if there are any other last minute kind of points or questions that people want to bring up before we start to transition out of this.
I'll just say thank you again for the invitation. Adie and I don't think we're evangelical, but we are people who love to proselytize about palliative care in the rural setting. So thank you for the opportunity to share something that we're both quite passionate about.
We are always happy to spread the good messages. So you guys are doing great work. All right. Well, going once, going twice in terms of last minute questions. I'm going to do one last screen share as you think about that, but feel free to interrupt me if you do have one. I just want to remind our UW affiliated folks, this is the process for claiming CME. You have about an hour, I think, after this is done to get that in, if that's something you want and need to do. Some upcoming didactics. Our next one is our very own Dr. Gaster, who could not be here today, unfortunately, but we'll talk about the work that they are doing in cognition and primary care, which is a wonderful companion program to Project Echo Dementia. Then we've got a few other topics coming up for the rest of the year. We'll have one session in November, one in December, and then we'll be ready to hit the ground running in 2025. So this is our next session next Friday. Ooh, Friday the 13th, or 2 Fridays from now. We will look forward to your input from our 1-minute post-session survey, which should be hitting your inbox anytime now. And I'm going to stop that and